Welcome back. Now we have two people who've signed up to give a public comment. I will announce your name and your organization, and our moderator will unmute you so you can speak. So I want to open it up to Ann Hubbard, the Director of Health Policy at the American Society for Radiation Oncology.
Hi, Dr. Casal and members of the PTAC committee. Can you hear me?
Yes, we can.
Fantastic. I don't think you can see me, though. I guess there's no video option.
No, there's no video. Yeah.
Okay, good stuff. That's fine. It's probably better that way. So again, I'm Ann Hubbard. I'm Director of Health Policy for the American Society for Radiation Oncology, or ASTRO. I want to say, first of all, thank you all for the very informative two-day discussion on population-based total cost of care models. It's always very exciting for people like me who are kind of health policy wonks to hear from the rock stars in payment reform. So this has been very informative. As you all may know, radiation therapy or radiotherapy is the use of various forms of radiation to safely and effectively treat cancer and other diseases. Radiation therapy works by damaging the genetic material within cancer cells. Radiation oncologists serve as key members of the cancer treatment team that also frequently, of course, involves medical oncologists and surgical oncologists. And I really appreciate that there's been quite a bit of discussion around oncology care over these last 2 days. So I certainly appreciate that. In the discussion, there have been significant areas of alignment between the discussion that you all have had and ASTRO's comments that were issued in response to the PTAC RFI on total cost of care models. And I thought I would just kind of walk through some of those that are really top of mind for us. First of all, of course, is upfront funding to offset the cost of transitioning to value-based payment. Some of the work that we put into the RO model with our members as they were preparing to participate in that particular payment model indicated that there is a significant amount of time and effort and cost associated with transitioning to value-based care. And I think this is important to consider in any future total cost of care efforts. Other areas of alignment include incentives for integrated care coordination. There's been a lot of discussion about PCP to specialty, but even I would add within specialty care models, there should be incentives for collaboration. Of course, cancer care is a good example of that, with so many specialists who are very much involved in a cancer patient's treatment. Recognition of guidelines concordant care is another area of alignment, as are ensuring that the payment is reasonable and sufficient to cover expenses, as well as providing additional reimbursement, recognizing that care for higher risk populations tends to cost more. And so therefore you need to be able to invest in wraparound services to ensure that those patients have continued access to care. And the final item I wanted to raise is the need to provide timely data sharing. This is another key area where providing that data helps practices make that transition from fee-for-service to value-based care, and understanding kind of what those predicted payments will be and how they might be able to operate under a value-based payment system. These key areas of alignment also happen to correspond to key areas where CMS's RO model or the radiation oncology model actually fell short. Unfortunately, that model involved an overemphasis on demonstrating savings that really sacrificed the achievable goals of quality improvement and payment stability. Despite the indefinite delay of the RO model, ASTRO remains committed to working with CMS, PTAC, and members of Congress to establish a radiation oncology payment reform initiative that contributes to President Biden's strategy to reduce cancer mortality. We want to ensure that we can establish a payment model that includes a simplified payment methodology that ensures fair and stable reimbursement, recognizing the efficient delivery of care. Additionally, there should be investments in cancer treatment infrastructure to ensure that all patients have access to high-quality care using advanced technology. Secondly, there should be mechanisms to establish a payment model that identifies and supports those patient populations with limited access to radiation therapy to ensure that they are able to initiate and complete their treatment. Additionally, a commitment to evidence-based approaches to care and investment in wraparound services, including patient navigation and transportation, will improve care for patients who are from historically marginalized populations. And finally, within a population-based total cost of care concept, there must be a pathway for these types of models to recognize the value and quality of radiation therapy within a broader continuum of cancer care. Incentives that include and encourage multidisciplinary collaboration, as well as the inclusion of discrete or nested episodes that recognize the value of services like radiation therapy in multimodality treatment, really must be part of that overall equation. Again, I really appreciate the time and appreciate the discussion during the past 2 days. Thank you.
Thank you. Alyssa Newman, from the a health policy analyst from the National Association of ACOs.
Good afternoon. Hi, are you able to hear me all right?
Yes, we can.
Okay, great. I'd like to start also by thanking the committee as well as all the PTAC staff for the time and attention that have been dedicated to these important discussions around population-based total cost of care models this year. NACOS and our members are committed to improving the quality of care delivery, population health, patient outcomes, and healthcare cost efficiency. And clearly we have lots of feedback on this and provided detailed remarks in response to the RFI, but today I'll highlight a few key points on incentives and payment strategies. First, appropriate incentives are necessary to ensure success when shifting risk downstream to providers, which is why Congress established the 5% APM bonus payment. However, as Kristen from LTC ACO noted yesterday, this bonus is set to expire at the end of this year. And while we're strongly encouraging Congress to extend the bonus, it's also critical that policymakers consider additional incentives to promote increased and long-term participation in risk-bearing APMs. And in addition to financial incentives, we'd like to highlight that waivers and increased flexibility can also encourage providers to join APMs and support care delivery transformation. This can include, as others have mentioned, access to timely and actionable data and use of telehealth, as well as some beneficiary programs, such as being able to cover transportation or wellness programs. All of these can enable success in a population-based model. In terms of payment strategies, we'd like to see payment strategies for a population-based total cost of care model include optional capitation payments for primary care. Strong primary care is critical to success in a population health model, and these types of population-based payments can better support comprehensive primary care that improves outcomes and reduces unnecessary care and avoidable hospitalizations. And it's also important to include appropriate flexibilities for providers to select the risk and capitation options, as well as other downstream payment arrangements such as bundles nested within an ACO that meet their needs and recognize the practice's ability to manage risk and administer capitation. Finally, fair, accurate, and predictable financial benchmarks are fundamental to provider success and long-term financial sustainability in a population-based total cost of care model. We heard from several speakers yesterday about some of the challenges with relying on fee-for-service expenditures to inform APM benchmarks as more providers move away from traditional fee-for-service payment to participate in APMs. As policymakers explore moving towards administratively set benchmarks, a thoughtful approach will be necessary and should account for regional variation in spending and spending growth, work to address health equity, and create parity and alignment across programs and payers. All around, sound program fundamentals around benchmarking and risk adjustment methodologies, and an appropriate balance of risk and reward are necessary to attract participants and ensure ongoing success in a population-based total cost of care model. We know CMS and other policymakers are exploring ways to improve these methodologies, and we look forward to working with many of you on these policy improvements. I'd like to say thank you, and if people have other interest in our comments, you can read our full RFI response on the PTAC page, and you can feel free to reach out to us with questions. Thank you all so much.
Thank you. Thank you for both public comments. I'm going to check with the host before we move on. Are there any other folks who want to contribute? No. Okay. So hearing none, that's the end of the public comments. So now the committee members are going to discuss what we've learned yesterday and today from our guest presenters, the roundtable discussion, background materials. PTAC will submit a report to the Secretary of HHS that includes our findings from the March and June public meetings, in addition to what we want to highlight from yesterday and today. Similar to yesterday, we'll start with time to reflect more generally before staff continue with the slides identifying potential comments. So with that, I'm going to turn to the committee thinking through the conversations today specifically. Any particular areas come to mind that we want to be sure we highlight or think about for the report to the Secretary? Bruce.
Yeah, thanks. I'm trying to find the name of the presenter. Kate Freeman from American Academy of Family Physicians made a very good point at the end of their session about fee-for-service, and I think we need to, as we write on this, because I think we are in agreement that we want to take a position that at least, if we don't use the word uncomfortable, at least guides us away from reliance on fee-for-service. The point she made was that if that's the stick, she didn't say it this way, if that's the stick, what's the carrot? And we'd like to think that the vast majority of providers who are depending on fee-for-service have an alternative, an ACO, a population-based something. But she made the point that not all of them do. So I think it would be wise to acknowledge that, well, first of all, we're not trying to be punitive to people who are in fee-for-service. We're trying to enlarge the incentives to moving to value-based care, understanding that not all of them can do it right away, and so that I think maybe the word glide path could be in that description somehow. So we're not saying let's do it tomorrow, but let's move in that direction.
Great, thanks, Bruce. Jennifer?
I know we've commented on a lot of the themes that we've heard about already, but I'll summarize 4 that I heard and I think are important. We just keep hearing over and over, data, data, data. How do we share? How do we access? What are the definitions? How is it actionable? And then ultimately that also leads into benchmarking and risk adjustment. I think we cannot continue to prioritize that as an opportunity. Second, I heard today, which I hadn't thought about before, but I think it was a really nice distinction, and that's in the current business model space where we talk a lot about care models and payment models, but ACOs is the business model, that maybe we shouldn't think of them all the same. And that's a description today we heard around a hospital-based ACO model, a provider-based ACO model, and then a distinction was made between a primary care specific based ACO and one that includes specialists. And that kind of rubric might be helpful as we then think about payment models, because certainly that kind of infrastructure influences care models. The next is that we heard about multi-payer engagement, and I think today really hammered home that it's not just around engagement, it's around alignment. So the discussion around, again, data and quality measures and where there's an opportunity to decrease administrative waste in the system by creating that kind of alignment and improving outcomes. And then last but not least was this idea around for at least some specialties, and the conversation was primarily focused around primary care, but the idea of a prospective payment, and a business cannot manage its risk if it doesn't know ultimately what its revenues are going to be. And so for services that we think are essential, this idea of a prospective payment and really drilling into what does that look like, who is it for, and how does that move us into ultimately this idea of creating deliberate incentives to create a tipping point for participation, which also, I liked what Mark McClellan's note was, still creating a landscape where there's innovation and flexibility.
Great. Thanks for those summary comments. Lee?
Really enjoyed the presentations today. I've got a number of kind of take-home notes to me, and most of these multiple speakers touched on, but in only the chronological order that I took the notes, but I'm all talking about that the clearest data available supports an overlap of population-based total cost of care model and a nested-based model, which I just thought was really insightful and interesting. So it's not a conclusive data set. It's a real-life experiment, but the current CMMI policy of trying to structure and define these very, very differently so that they're completely excluded for a clean data set in comparators doesn't support that. And that just may speak to earlier comments yesterday that the APMs are essentially becoming ubiquitous in many markets, and so it's really, really hard to get a comparator group. And so there's kind of a disconnect between the pilot mindset and framing up CMMI's initiatives and what we see that there's actually marginal benefit to the overlap on purpose, and maybe I'd be encouraged to push that direction. So that was one take-home point for me. The second, I love this. Eric had this really interesting phrase yesterday about we're needing to move towards a quality accountability infrastructure. Love that phrase, but it did immediately speak to me that that's only going to be possible when we move health data to a health data utility or infrastructure model. And there's a real tug of war right now between a federated, disconnected pull system like Commonwealth, operated by the EHR vendors, and a HIE national backbone push system utility model where health data is under the appropriate controls is ubiquitous like electricity. And so I think that was really an important dichotomy set up for me. The comments that Eric made about measuring health equity just takes a very, very large sample set, really hit home that there's going to be a rush in many settings to move these quality metrics down to a provider group. And his implication was, even at large health systems, data set may not be big enough to make them accurate measures. And so they may really only be health plan, Medicare, Medicaid level metrics. So I think there's going to be a rush to move forward faster than the science lets us there, and that's kind of interesting. I think I heard several comments that settled it in my mind. We've been talking about nested in versus carved out specialty-based models in a population-based model, and I heard fairly clearly that most experts are thinking actually a total cost of care population model for everybody, consistent with CMMI's direction, and then specifically focused episode of chronic disease nested models make sense, and there's good support for that. No one spoke to a carve-out model. Although Larry and I had an aside that Medicare's current treatment of VSRD and dialysis is essentially a massive carve-out model. And there was some focus, my last point I'll make is there was some focus on starting this transition from purely fee-for-service. Often the earliest, lowest hanging, easiest fruits are all in primary care investment and data infrastructure, but that isn't, and we had several people speak to this, isn't where the majority of healthcare dollars are directed. They're directed in specialty costs. And so that's, more expensive and more difficult to get at and takes all these interlapping incentives that we've been speaking to get towards. So that was interesting. So that concludes my remarks.
Great comments. Thanks, Lee. Larry?
My additional comments today over what we discussed yesterday was from two Marks, from Mark Friedberg. Even though the structural recommendations into the ACO were based upon grant at this point, we do see the health plan trying to influence the infrastructure of the ACO by incentivizing them to put patient-reported outcomes measures in social determinants of health equity. It's being done at this point based upon an independent grant, but you can definitely see that is not a trend that's going to stop there. Mark McClellan, I thought his slides were outstanding, and specifically, some of the slides around where the true cost of care is, the longitudinal view of where cost of care is. I thought it was fantastic, but I really focused the most on his vision of how to implement specialty nests inside ACOs. I really liked this concept of base payment for taking the care of this patient with whatever condition it is, and it's based on the patient. So it's a patient-specific payment based upon their disease, and I guess it would have to be on their constellation of multiple diseases. But then the procedural services are then brought in bundles that are most likely under the typical fee-for-service payment for those, so that you start ratcheting in the adjustments that you have to make to get specialists as part of the team, embedded with the team, working with the primary cares. That's why they're getting their base payments. And although they do get supplemental payments for procedural services, they're bundled, they're restricted a little bit. I really liked his granularity there. And then finally, we heard over and over and over again, strong disincentives for perpetuating the current fee-for-service system. Certainly would everybody spoke similarly on it, and I think it's going to take more than just freezing the payments.
Yeah, thanks, Larry. Josh?
Yeah, great presentations today to supplement what we heard yesterday. Still have to probably fully internalize everything, but just some thoughts that I have right now. Going back to that our PCDT presentation, thinking about the spectrum of different methodologies, if kind of more pure fee-for-service on one end, capitation, which might be exemplified by Medicare Advantage on the other, and kind of fee-for-service-based APMs in the middle. I agree with others on the committee that people did talk about the limitations of our current fee-for-service system, but I think it was also, want to acknowledge it was mixed, right? We heard things like, well, fee-for-service, if you have global budgets or other parameters around it, that changes a little bit. You can't pull the proverbial rug out from underneath people, if you want to, if there's no good place to go. So I want to just say it's more nuanced than that, and I think our comments should reflect that. On the other end, I think lots of good things about MA. I also heard comments about how we are subsidizing that, and as penetration gets to a certain point, you may not have a lot of room to promote other types of payment models if it gets there. So I think even one commenter said, are we thinking about MA as an APM? And I think those are important things to reflect as well, that force on that side. And then focusing on kind of the middle, kind of the fee-for-service-based APMs, two themes that I organized the comments around were opportunity and certainty. So, whether the opportunity comment was made in terms of extending the 5% rate increase or, using an external benchmark to create more room and to avoid this ratcheting effect, the opportunity seemed like it jumped out to me in almost every session we had. And then the certainty about, is this model going to change in a few years, certainty around revenue, and certainty around, where are we headed with the inevitability or lack thereof of these APMs. So I think opportunity and certainty to kind of create that middle space if we want it, and then acknowledging kind of the mixed nature of the two at the ends. To me, I would love to see that, those highlighted. And then finally, I think a few commenters noted that this idea of short-term and long-term, and I think a few people appropriately orient us to say, what do we want the payment system to be? And there are going to be puts and takes, but in the short term, not allowing the short term, I don't want to use the dog and the tail analogy after today's slides, but not letting the short term affect what we want in the long term, budget savings versus, program savings and what we want to design. That's tough, but keeping the eye on the big picture.
Great. Thanks, Josh. Walter?
So, great two-day session. I also appreciated all the committee members' comments so far, very thought-provoking. I was reflecting upon our meeting back in June, which was focused on care delivery, and one of the things that I felt was a strong thread running through those 2 days was the outsized impact investments in primary care could make in achieving a sustainable, thriving, value-based care model. In contrast, I think these 2 days that we just had kind of emphasized the importance of engaging in specialists and doing so in a thoughtful way that made them feel part of the movement. I think Mark McClellan's comment that many specialists appear to be unaware that they are even part of an ACO struck me. And actually, as I reflect upon it, it rings true to my experience as well. And this whole idea that ACOs are for primary care providers, another point that Mark brought up, I think speaks to the both the challenge and the opportunity that we had before us in terms of engaging specialists appropriately. I also really appreciated the comments by CMMI this morning as well, and kind of their thoughts about it. But just kind of, I think, and I also think that many of our experts, starting with our first session yesterday with Mike and Mark, and all the way to our last session today, talked about what Larry mentioned in terms of having nested bundles of specialty care within a broader total cost of care construct. I think that all kind of makes sense intuitively. Ultimately, though, I think there's a lot of detail to be worked out. Just for example, the Astor comment we heard just now about radiation oncology. You got to think about colon cancer, for example, and the involvement of maybe the gastroenterologist, the colorectal surgeon, the radiation oncologist, the medical oncologist. How would you construct a episode of care? Who would hold the risk? How would that bundle be constructed? All very difficult questions, and I think it would be really informative for us to kind of learn more about what's been done out there. So that's one request of the March PCDT for next year. As we look at this, maybe we can look for some experiences that can speak to some of these complexities. The other aspect that was mentioned in passing but not quite delved upon to the same extent by our experts was the specialist involvement in chronic care, so congestive heart failure or inflammatory bowel disease. How are specialists to be engaged in chronic care under a value-based system? So a lot to think about, a lot to learn. I felt like these 2 days were very productive, and look forward to our sessions next year.
Great. Thanks, Walter. Thanks for those comments. Angelo?
Yeah, thank you. So I'll echo, I think yesterday and today were just great days, lots of great information, a lot of expertise. And I agree with everything that's been said around the table. A couple of things that I would just add is that I also very much liked Mark's presentation and liked the slides he had, liked the payment model he had. I think that can be a solution to a lot of the specialty engagement nesting within an ACO. When I saw that slide, though, once I got past, that's the fix. Trying to think from an operator standpoint, how to operationalize that and the data that's going to require, the staff that's going to require, it's a big project. And then I think most ACOs today, the amount of savings that they generate today is minimal. And once you start spreading that around the primary care docs and the specialists, and the specialist at the end of the year gets a check for $1,000, and it nowhere near covers his efforts in terms of participating in those kind of models, particularly if you're looking at just an MSSP group of patients. And so, and then I remembered Kate's slide, where she had the Medicaid on one side and the Medicare on the other, and all those individual contracts in between. and her statements about not being able to have enough bandwidth to participate in all this variety of ways that payers want to do that, it really hit home again that either those that can have got to move into global risk, where they're taking the global risk, they've got enough upside potential to be able to cover those costs and worth the investment to make those things happen, but that's not everybody in the country. And so again, I think for us, it's how do we encourage people to move further up that chain to global risk, and then how do we help incentivize multi-payer models? Because until all those blocks in Kate's slide get aligned, there's not going to be enough volume of patients for the specialists to want to nest their programs in an ACO and really be productive enough to make it worthwhile. So I think, I know this committee is more, for the Medicare products, but we've also got to be thinking about, along with others, how do we create a multi-payer environment.
Great, thanks, Angela. Jenny?
I iterate how these 2 days were really incredible as far as being able to engage in the dialogue and listen to these experts. A couple of things that struck me was, one, a few people brought up the concept of being able to involve specialists by doing teleconsultations and bringing that into rural areas. I think that that's an important thing to embed into compensation mechanisms, and particularly parity for specialists, because, without that level of parity, it's still the time that they're spending. Loved Mark's illustrations and slides as well, and I think that as you start to break down how prospective payment can function in a specialist world, it's good to look at, there's only one healthcare dollar. And so when people think about things like workload credit and prospective payments for specialists, that has to come out of somewhere. So just having some insight into, is that when you do a prospective payment, does that mean that you're disincentivizing procedures? And so then when they do a procedure, it gets reimbursed at a lesser rate. I think these are things to kind of, for people to look at. The other thing that I found really insightful was at the very end, Nancy Keating mentioned a methodology, and I know Lee and I looked at each other, and it was about an equity payment that would then not count under the construct of the total cost of care or benchmarking, and it was like that $30 equity payment. I found $300. I found that particularly insightful, because I do think that that's a way to sort of balance both things.
Yeah. Great. Thanks, Jenny. Lee?
I was just sitting reflecting on all of our comments and take-homes, and something kept resounding to me is that we keep talking about, we have to incentivize this and incentivize that and incentivize the other. To Cheney's point, exactly, there is only the healthcare dollar, and it's not going up, or it's not going up indefinitely, right? I don't know if there's any other leadership culture change geeks here, but the GE Accelerator model, we're focusing on the glorious future, and I'd say a modest incentive to already highly compensated physicians is not a glorious future they're going to charge towards. It's maybe a modest inducement at best. The other part of that change model, however, is a burning platform behind you, and that speaks to the inevitability that's been lost. And so all that to say, I think we really do need both sides to get this to tip over. And that takes me back to, we should not shy away from figuring out how in a modulated, carefully thoughtful fashion to make fee-for-service a very uncomfortable place to be, that ratchets up in its own comfort over a predicted and transparent time frame, right? I did appreciate Kate's comment that there are plenty of physicians practicing in rural areas where there are no options, and fee-for-service is the mechanism. But unless they see a future that's better and a path that's burning up behind them, there isn't any motivation to change that situation. And there are multiple, we have heard from Alidade multiple times, there are many really effective, good ACO models that operate in rural areas all over the country. So I don't think that should let us shy away from our guns of trying to make a model that changes incentives and makes fee-for-service uncomfortable.
Great, thanks, Lee. Bruce?
With all due respect to Ginny, Ginny and Lee, I wouldn't say there's only one healthcare dollar. I'd say there's $3 trillion healthcare dollars, and which makes me want my last public comment on this committee relate to the reason I think I was appointed to the committee and to begin with, which is we've got a well-funded, possibly overfunded healthcare system, and what, in the very broader context, what we're thinking of as transformational ought to at least bring the rate of increase in that $3 trillion down, if not the absolute amount, and still be plenty of funding to provide good care to Medicare beneficiaries and others without any loss. So we're a lot of what we should be thinking about is, focusing our attention on what's good for the patient, which is easy to say. But we can do that, I think, without having to say, well, we've got to fund this and we've got to fund this and add dollars to the system in order to grease the skids to move where we want to go.
Thanks, Bruce. Appreciate that. The only other comment I'll add, and again, all the comments have been great, is I thought we heard the word mandatory more than once in the last 2 days. And it wasn't so much mandatory that, physicians won't do this unless we make it mandatory. It's really the thought, a couple of things that were brought up is that, again, the growth of MA has taken a large piece away. If you just rely on voluntary, it's going to be very hard to test things going forward. And the fact that we've had, we saw the analysis oncology care model, but there's been a fair amount of analysis around voluntary, and there's been, some wins and some sort of areas where maybe the models haven't performed as well as we've liked, but we're still sort of in this testing and pilot phase, and I think we're at a point where more of these need to be mandatory in order to more expeditiously evaluate them so we can move things forward. So I thought, having heard that from more than just one of our presenters, I think that was interesting. Oh, Jay.
Out of sight, out of mind, hey, Paul.
No, I was looking for the little yellow hand, Jay, on the
okay.
Go.
No, obviously, not a whole lot to add after what everybody said, but I just want to focus on 2 points. One is, and it was alluded to yesterday almost in passing, but I don't believe enough, and that's, we focus on the patient, but at the end of the day, we're always talking about physician behavior, but that translates down to patient behavior. So how do we get the patients involved? And a lot of it has to be done through benefit design. Because if you don't think the specialists know they're in the ACO, I guarantee you no patient knows they're in an ACO. If you ask the average patient what an ACO is, they probably tell you it's a streaming station. So I think we've got to do a better job on the patient education side and have the benefit design be in concert for the behaviors we're trying to drive. And I think, Mark McClellan's point that 60% of the care and expense is delivered through specialists, part of that is just a real elephant in the room that, we've got 500,000 specialists in this country, and we've got about, when you look at family practice and general internal medicine, about 200,000, let's say, primary care physicians. The rest of the world, especially in the European countries, that's flipped. They're 70-30 primary to specialists. So we've got to figure out specialty compensation if we're going to be successful in either bending the curve, reducing cost, or increasing quality.
Thanks, Jay. Appreciate those comments. So now, Audrey, I'm going to ask you to continue walking us through the slides. And I know we have a few areas to try to hopefully we can get through. So I'm going to turn it over to you.
Thanks, Paul. So in the interest of time, I think maybe we will finish up the discussion about, I think we were looking at enablers to support desired care delivery features. I believe that was the next one we were going to discuss. That is, it's 4A. So 4A, I think a lot of this does overlap with some of the things that were discussed today.
Yeah.
And so I guess one question is that it could be beneficial for us to update the comments that we have so that they incorporate what you guys have said, so that we're not kind of repeating what we just spent a half an hour discussing. That might be more efficient as opposed to kind of taking the comments that we have as written. I think in some cases we may already have some of the things that you said, but in other cases we are not fully capturing that. So, for example, on the real-time access to actionable data, we have 2 bullets. There probably are more bullets just based on what you guys have already discussed.
Yeah.
We had access to information and metrics on best practices. We've had a couple, actually 3 presentations today on performance metrics. And infrastructure investments, we've heard a lot regarding, and probably need to further refine what we have there. So I guess my suggestion would be for staff to kind of go back and update what we have here to incorporate the comments that we heard from you guys over the past 2 days, and then come back to the committee as we're drafting the report to the secretary. I think, Steve, does that make sense? I think we've pretty much heard. Are there any other questions that we need to ask the committee in the context of preparation for the RTS?
No, I think that it covered.
Yeah. So I think our main goal is just to make sure that we've heard from you what we need to know in order to prepare the RTS. So I think we've got what we need.
Oh, okay.
Yeah.
Great. Okay. Wow. So I want to thank everyone for participating today, our expert presenters and panelists, my PTAC colleagues, and those listening in. We explored many different facets of payment within population-based total cost of care models. Special thanks to my colleagues on PTAC. There was a lot of information packed into these 2 days, and I appreciate your active participation and thoughtful comments. The committee will work to issue a report to the Secretary on what we've learned over this year on population-based total cost of care models. On a personal note, this is my last PTAC meeting as a member of this committee. It's been a privilege and honor to serve as chair of PTAC as it undertook this important work on population-based models. I will also note that it's also the final public meeting for my colleague, Bruce Steinwald. He and I were part of the original group of PTAC members appointed shortly after MACRA was enacted in 2015. We both reached our term limits on the committee. And again, I think I speak for Bruce when I say it's been an absolute privilege to be a member of this committee for the past 6 years, 7 years, 7.
Yeah. Arithmetic was never your strong suit. But I feel the same way. It has been an honor and a privilege, and I'm going to miss all of you.
Yeah. Thanks, Bruce. So together we've been able to watch PTAC evolve over the years, and I think we're both eager to see what you do next. Thank you all. It's been a pleasure serving with you, and with that.
Paul, before you close, just and I think I probably represent the entire PTAC committee just in public. I wanted to thank you, Paul, and you, Bruce, again for your leadership over the last 7 years and just what a wonderful job you've done leading this group and getting us to where we are today. So I just wanted to say that publicly.
Well, thank you all so much, and with that, we will adjourn the meeting.
Produced by the U.S. Department of Health and Human Services.